Hello, I'm Ronnie Eldridge. Welcome to Eldridge & Company. Ann Culkin walks into a room of gloom at Memorial Sloan-Ketering Hospital and with her comforting voice and obvious professionalism immediately puts hope into the air. She has about the toughest job in New York, but you'd never know it when you talk to her. So what do you think that toughest job, what is that tough? Let's tell everybody what that toughest job is.
The toughest job is walking into a room and meeting strangers for the first time who've been diagnosed with cancer. I'm a specialist in lung cancer, so those people have just been told that they have lung cancer. And the challenge begins with a treatment plan for those patients and their family involvement and how we will execute a true plan of attack on improving their life.
You're what we call an oncology nurse.
Yes, I am.
And how many, you told me before, how many? There are 30,000 oncology nurses?
I have just returned from the 30th anniversary convention of the Oncology Nursing Society, of which there are 33,000 oncology nursing members.
And what does that mean exactly?
Well, those are nurses who specialize in oncology care. It was started by a group of nurses who met after a research meeting in 1974. 6 people sat around a table similar to this and decided we really need to advance our profession as a specialty in oncology. And so out of those 6 women meeting, formed the Oncology Nursing Society. And it has accrued members, and it has developed a certification where you are a true specialist in oncology care.
So do you have to get certified? How do you do that?
You can get certified. It is encouraged actually to be certified, and by sitting for an exam. They also continue certification in a new process where you can develop continuing education credits, and they count towards your recertification.
So this is Oncology Nurse Month.
It is. May is Oncology Nurse Month.
Right.
Yes, it is.
And so you had a convention in Florida.
Yes, we did.
And what happens at these conventions?
Well, at these conventions, many of the members are, and anybody can do this, and no matter what your level of education is, as far as being a registered nurse, you can be a baccalaureate degree, an advanced practice nurse, a nurse practitioner, even a PhD nurse. And you submit your ideas of research or teaching tools in a variety of forms. It's reviewed by a forum of nurses in a blinded review process. And for instance, I submitted something on a brand new drug that was developed and its side effect profile, just to teach a way of teaching and exchanging information. So my submission was submitted in a poster form. So try to explain that to patients, and particularly my mother, what a poster was. She thought that I had, you know,
a poster.
a poster. And in fact, it's a true research process of how to develop and implement a plan of care for people affected by perhaps drugs, psychosocial care, and they're all reviewed. Other nurses are there to teach in instructional session forms or even podium presentations.
And the nurses are very anxious, especially lung cancer, well, all nurses, but I know from you, lung cancer nurses, oncology nurses, are anxious to go out and talk about this more to the public, right?
We truly are. We have a passion about smoking, smoking-related illnesses, the link of smoking to many cancers, not just lung cancer, but that of bladder cancer, ovarian cancer, and even how smoking affects normal lung. People develop emphysema, people develop chronic obstructive pulmonary disease, smoking affects fertility. Smoking can affect the children the most with sudden infant death syndrome, the risk, as well as childhood asthma.
So what do you think when you see people smoking?
Well, I get annoyed. I get annoyed with the culture in which we live in the country that we live in, where we have, smoking is the major link to the development of lung disease, number one. It is also a link to developing lung cancer. And somehow we miss the message. We haven't taught people how bad smoking is. There's a generation of kids, particularly older in their 20s, who continue to smoke. We have a little generation, your little grandchildren know smoking is bad. But when you're in your 20s and even college age, we miss the message. You know, Joe Camel was part of their growing up. And for some reason, they miss the message about smoking and its hazards to your health.
So what kind of campaigns do you do? Do you go out and talk to people? Do you pressure tobacco companies? Do you lobby in Washington?
We do all of that, yes.
Yeah.
Particularly where the tobacco settlement money goes in each state that have these huge settlements, and the trickle-down effect of that money. And unfortunately, you never see it at the bedside or even in prevention campaigns. So we're always anxious to get a lot of that money to help nursing and use it in prevention, because if you can prohibit people from starting smoking as well as smoking cessation, you have better outcomes, obviously, and people will live longer. There's estimated that this year 440,000 people will die in the United States from smoking-related illness.
Isn't that incredible?
It's amazing
now,
amazing
a lot
number.
of people, though, get lung cancer who have not been smokers.
There is an estimated approximately about 17,000 people every year get diagnosed with lung cancer who have never smoked a cigarette in their life. The development of understanding genes, or the development of the genome, is probably going to propel us in this century to understanding the why of that happens. We have no idea.
And do you find that more younger people are developing, or it's being identified more in young people?
We have younger people, and we have younger women who are developing lung cancer. Whatever reason that is, we don't know. We know that a smoking history in men cuts off 13 years of your life. You will live 13 years longer than the estimated average. And in women, it cuts your life off by 14 years. So smoking is a hazard.
Isn't that something? So how did you become a nurse?
I became a nurse because my mother said, you should be a nurse.
And where did your mother get that idea?
I think probably it was her own passion of wanting to be that was never realized in her life.
Yeah. You grew up in Scranton, Pennsylvania?
I did, yes.
Yes. And you have how many siblings?
I have one older brother and 2 younger sisters.
Yeah.
And my mother's comment to both my sisters was, of course, in her female-dominated nursing profession idea, that be a nurse first, then be what you want to be, because you'll always have a job.
Well, that's true, isn't it?
It sure is.
And nursing is an occupation. I wanted to be a nurse when I was young, and my parents said, well, you've got to go to college first, you know. So then I took zoology, and I got 9 points a D, and I switched to political science. But somehow, what is it? I mean, you didn't have to get dragged to nursing school.
Not at all. And it's funny because I think my mother saw the passion in me at a very young age, and my need to be needed, my sense of nurture for my younger siblings. And she was able to identify that I would probably make a really good nurse.
Yeah.
And 19 years later,
And you love
right.
nursing.
I do. I absolutely love it. You know what? It is truly the art of having a palate, because not every nurse is at the bedside. The profession itself has grown where the education of nurses is so empowered, that being insurance companies, that being in prevention, that being in clinical trials. Nurses really play a role in a variety of ways. And that's what I love, how to recruit people.
So what do you do?
What I do every day, I work in a collaborative office practice setting. So I actually work with a group of physicians, one in particular who specializes in medical oncology, or that being lung cancer. And I function as his eyes and ears, using via telephone triage, talking to patients on the phone, doing all of their education when they're first coming in with their treatment plan, and then follow-up care.
And how does, it works that you have what you call clinic days, and that's when the doctor's appointments are scheduled with the patients?
That's true, yes.
And
so 2 days a week, we see patients all day long from 8 o'clock in the morning till we're finished at night, and those are all lung cancer patients. And then the other days of the week, I pretty much am doing follow-up phone calls, symptom management on the telephone, education, and developing education tools, developing tools to teach other nurses, even as far as I just got involved with developing a newsletter for the nurses at Memorial Sloan-Ketering.
So everybody is trained more than just working, what are nursing schools like? When I wanted to be a nurse, most of the hospitals had their own nursing schools. I think it was 2 years or 3 years, 3 years. And then you were a nurse.
Yes.
But nowadays, you go to college? You have to...
Programs like that still exist. However, the baccalaureate degree programs are by far what has taken over the educational process for nurses, yes.
Right.
So those patients do have classroom time, but they do have the clinical experience.
And then can they come right into Memorial Sloan-Ketering, or what do you have to do before you become a specialist in something?
Well, we actually do take new graduates right out of nursing school. Those are the prime time to really develop a nurse and foster her growth and development in oncology. The truth of the matter is, Ronnie, oncology is a total system disease. It's not just about the lung cancer, but you're always looking for other system failures. For instance, giving the delivery of chemotherapy. You want to make sure their kidneys are okay. You want to make sure that they can eat and drink. People that go to surgery and have major cancer surgeries their performance status is that of a caliber where the nurse really needs to foster and help them be ready for surgery and then take care of them in the post-op period. people that have radiation, those nurses really understand the process of understanding fatigue and understanding the need for proper hydration while undergoing radiation therapy, as well as the post-care of their skin changes that may occur from that.
And so do you have programs that are like internships and, I mean, are there different levels that you have to go through?
We do. We will actually take summer externs or students or nursing students who are still in school and actually bring them to an extern program, particularly at Memorial Sloan-Kettering Cancer Center, and other hospitals in the city actually do this as well. And that's where you can really tap in to show them the potential of what it is to be an oncology nurse.
And people come from other places, other hospitals too, to
Unfortunately, in the
learn.
United States, we have a terrible nursing shortage. And we have a nursing shortage not only in nurses at the bedside, but we have faculty openings all over the country where there's not enough faculty to teach new nursing students. So the truth is we have a lot of nurses who come from Philadelphia because there isn't enough clinical experience in the Philadelphia area. So they come to like Cornell or New York Presbyterian for that clinical experience of the specialties.
When you said Philadelphia, I thought you misspoke and meant the Philippines, because we have nurses coming from other countries too, right?
We still do. As many of you may recall, there in the late 70s into the 80s, we had a huge influx from other countries because we just didn't have enough here in the United States just to meet the demand.
Now, nursing there's always been an ebb and flow, it seemed to me. I mean, there was a time when nursing was so subordinate to doctoring. But now there's a new look at nursing, right? You have nurse practitioners, you've got nurses who are assuming more responsibilities. How does all the legislation and all the costs of medical care, that enhances a nurse's role?
It certainly does, particularly in symptom management. And the NIH and the NCI are now looking at how well nurses can manage symptoms in patients, but also the time that it takes to manage people with chronic fatigue, with nausea, with pain, and the specialization of what the nurse and how the nurse plays a role in that. The truth of the matter is physicians and nurses work collaboratively, and that has really fostered an environment where physicians and nurses speak the same language to patients and really care for them.
And what do you do when you're an oncology nurse and there's so much despair?
You know what, there's a level of maturity that comes, and understanding that the life process isn't to be 90 years old. I mean, bless everyone who is, and you've made it. But each day matters. Every day counts. Historically, you know, particularly for people who are newly diagnosed, yesterday they were fine, their life was infinite. Today they have a lump in their breast. Life dramatically changes for them. And then what the future holds is still the unknown. But it was unknown the day before they got the cancer, too. But so to really understand that living in the present is what the gift is of the day.
Do you think that a lot of your nursing, that underlying philosophy and the ability to get through a day and everything, is part of your spirituality or your religion and what?
You know, I believe that plays a role in it, definitely, and then to understand the psychosocial, spiritual aspect and the emotional component that goes into the patient as well. So you have to understand your own thoughts and beliefs and understanding and the spirituality of which is in your own life in order to articulate or to understand the stranger that has just come into your life.
And are you able to help the stranger that come into your life to develop this?
Well, I think so, yes, because patients do have a higher belief oftentimes in that getting to the next level or what else can play a role in their life. As you well know, Eastern medicine has come in to play a major role in patient care in the integrative aspect of what that complementary medicine can do for patients.
Let's talk about that. I'd like to. That's very interesting. Tell us about it.
Well, integrative medicine is an identified specialty where you use Eastern medicine, that being acupuncture, herbs, vitamins, thought processes, reiki, meditation, tai chi, into achieving an elevated level of your cells, of your thinking, of your day-to-day things that you do, your activities of daily living, as we call it in nursing, to enable you to be feeling a little bit better. We think we can often do symptom management using acupuncture. We can often use acupuncture in helping lymphedema, patients who get swelling of their extremities from perhaps breast surgery or even any kind of lymph node dissection that's done. So all of that plays a role in the total package of what a patient can have. And
do you recommend this, and you provide these services at Sloan-Kettering, or do you go out, or you suggest to people that they do it?
We do. We actually have a whole department at Memorial Sloan-Kettering of integrative medicine. Many hospitals outside of the city have the same. Even at Columbia, the heart surgeon has a whole program about using thought process, thinking process via tapes before you have open heart surgery, even transplant surgery. So it plays a variety role in it. You can see it seeping into what we would consider non-cancer surgeries, such that being your gallbladder surgery, open heart surgery, even orthopedic surgery. And the healing time is actually faster, is what they found in research trials using this method.
So what is the upshot? It makes you stronger and more able to cope with a situation?
Well, we think that there's an autoimmune response, that you have an increase in different cells that enables you to heal quicker, just the power of your ability to think, to have focused thinking, can actually improve your outcome.
Isn't that interesting?
It's a fascinating, fascinating field. It's also interesting to get people to wrap their brain around it who've been taught the Western way of medicine.
Yeah, and we're taught a certain intolerance.
Oh, absolutely.
Yeah.
Absolutely.
And so they have, are they shocked when you first propose it? Some people?
Some people are. Yeah, I must say they are, or they poo-poo it as, I don't have time for that kind of thing. And but usually it's people getting along in their disease process or their treatment plan that they'll want to incorporate it into. Also, there's a market out there that people want to market this. Yeah. And I always tell patients, in the old days, you used to get a get well card or a funny T-shirt when you were going for surgery or even cancer therapy, and now people send you the $69 bottle of vitamins that they saw in the infomercial. So we're always careful about what people are going to ingest, because nobody has looked at that bottle of stuff with their chemotherapy, and maybe there's some sort of cellular interaction.
And what about food? Do you do nutrition lessons and guidance with nutrition? We
do. We are understanding more and more about the nutritional aspect of cancer treatment. And oftentimes, in America, in New York, we understand the power of healing. Food heals, and you need to eat, and that's often the family or the caregiver's complaint to the nurses. They just won't eat. Right. If he would only eat. And I often tell people, please don't get divorced over food. Yeah. It's not worth it. But the truth is, we understand nutrition and hydration. Everybody walks around the United States with a bottle of water, and we're still underhydrated. And if we understood, or we taught people more about drinking and hydration, what they could perhaps be drinking, it would help them feel better.
And macrobiotic foods?
Well, macrobiotics is a lifestyle change. So now you've been diagnosed with cancer. Are you going to truly change into macrobiotics? There is certainly a lot of research, there's a lot of case studies, personal reporting of how macrobiotics help people live longer, and even there have been reports where their cancer has disappeared. That's up for discussion.
Yeah.
It's difficult to do clinical trials to really take 200 patients and use macrobiotics in 200 patients who, eat the high-fat breakfast every morning and really understand what the outcome would be.
So let's talk a little bit about Memorial. I mean, is it hard to become a patient at Memorial?
Not at all. Not at all. And that's such a misperception of what Memorial Sloan-Kettering Cancer stands for. Memorial Sloan-Kettering Cancer Center is what we define, or what the state defines, as a tertiary care center. So truly, you can't walk in off the street, because we only treat cancer. We're a very specialized kind of hospital. Oftentimes, we get referrals from the outside via physicians. But the truth of the matter is, patients can self-refer themselves, given a diagnosis.
What other tertiary hospitals are there in the city?
The Hospital for Special Surgery. We consider it a tertiary care center.
For surgery.
Yes.
So I think that we should tell the viewers how we know each other.
Absolutely.
The fact that I met you when my stepdaughter, Rosemary Breslin, first came to Sloan-Kettering for her care. And were you then doing lung?
No, I was a brand new nurse at Memorial Sloan-Kettering. I was on orientation. And I had my preceptor, Mary Elizabeth, said to me, this is a patient who's going to be here for 3 days. I was already a nurse. I knew how to take care of patients. I didn't know how to work the pumps, and I didn't know where to document. I didn't even know where to hang my coat. So I got introduced to Rosemary. And more profoundly, I got introduced to you and Jimmy, because Jimmy yelled at me, and I yelled back.
So that immediately made
I actually didn't yell. It was my tone, I think, that I was more conscious of.
Why did he yell at you?
Because the pump was beeping, and I wasn't fast enough to get into the room to turn the pump off. And it annoyed him. And he came to the front desk and was banging his fist. And I turned around and said to him, you're going to have to wait. And he said, I don't wait for anybody.
Sounds like him.
And I entered the room and apologized to Rosemary, who took my hand and said, "I'm the patient, just ignore him."
Which is what
and
we
that
still
became
say.
a relationship. Although Rosemary did not have lung cancer, she had a blood disorder of unknown origin, the fact that she could not make red blood cells. So Rosemary was a frequent flyer, shall we say, to the adult day hospital, of which I floated through.
Is that what you call them? People who come often for treatment? Is a frequent flyer?
The frequent flyers, yes.
Yeah,
yes.
And there's a club? No.
No, there's not. But she was one of the people who required blood transfusions every 2 weeks and every 3 weeks.
Well, it was really through you that we've developed this total devotion, even though I wanted to be a nurse, for the nursing profession and recognition of what it means to have a nurse that really cares.
It's funny because I often tell families and patients, it's great that you have your own doctor, but wouldn't it be great if you had your own nurse?
Yeah.
Just to help. You know, we have a way of navigating through a system. We have a wonderful way of advocating. And truly, when you meet a patient, that's the first thing you're thinking about is how to advocate for this patient to get the best that they can have given their circumstances. So we look at, the nurse really is able to take on the patient and become part of their team. And their team may be them alone. Their team may be 9 other family members, or the famous daughter that lives in California who's going to be calling you on the phone. Yeah. But you really try to teach patients that you become part of their team.
And you don't mind when they call?
Never, never. And people constantly ask you, I have the stupidest question. This is a stupid question. I always say there's no such thing as a stupid question. The stupid question is the one you don't ask, because then you don't know. Knowledge is power, and the power to heal is maybe just a simple question.
So how does one accumulate the knowledge they need when they've been diagnosed with a cancer?
Well, the internet, which I often teach, can ruin your life. There is so much information on the internet, and patients come in with an expectation of what they've recently read on the internet or what their friend has brought over in 65 pages of things to review. But the truth is, understanding the disease and having a trusting relationship with your physician and that physician's nurse or his collaborative team, his or her collaborative team, and really putting your trust into what you want out of your treatment. Some people still, in the year 2004 or 5, which we live in, don't want anything. There are still people that can't say the word cancer. They come into Memorial Sloan-Ketering Cancer Center. They walk through the doorway, and we're not to tell them that they have cancer because their family doesn't want them to know, because their family's perception is that it'll be devastating to them. And yet, having the patient understand gives them the adrenaline to help them live. So it's a challenge, and we do the best we can to help those people.
What do you do when you see the people sitting outside of the hospital on York Avenue smoking?
Well, understanding that smoking is an addiction, that worse than cocaine and heroin. So, I would love to take them all to smoking cessation class.
Do you have that at the hospital? We
do. We have a big department of smoking cessation at Memorial, and with a terrific nurse who really helps people stop smoking.
But it is a scene, isn't it, to see them sitting out there smoking?
It's an amazing scene. It's an amazing scene to see nurses who smoke cigarettes. We live it every day. We understand the consequences of what smoking does, and yet the addiction to cigarettes is so powerful.
There's an identification, too, isn't there, between one cancer patient and another. I mean, Peter Jennings the other day was in the paper that he said he was walking out or into the hospital, and a woman stopped and called him by his name and said, "I'm one too," and then they hugged each other. Did you read that?
I did not, no.
I think you were away at your conference. He emailed a message to a lot of his friends and people at ABC, and he cited this thing that there's this feeling between people and for each other. Mm-hmm. I always had that feeling when I walked into the hospital. I mean, you're walking in there, and it's a hard road ahead of you.
Sure.
You managed to somehow take that dread away from people. I don't know how you do it, but it is an amazing kind of thing. The minute we used to get near you, somehow everybody relaxed and you knew it was going to be all right. Even when Rosemary was at a different hospital and you would come to visit her, It was just something.
Sure.
So do you go out and recruit nurses? recruit people to become nurses?
I do the best I can. I have a 7-year-old niece who wrote a whole essay about how she wants to grow up and be a nurse, and that is a true testimony to who I am.
Yeah.
But the truth of the matter is, there's no more Nurse Barbie. I don't know if you know that Mattel stopped making Nurse Barbie.
Oh, that's good. Isn't it? Or is that
no?
bad?
Where's the nurse?
You want Nurse Barbie?
Absolutely. There's a veterinarian. There's the McDonald's worker. All these Barbies, and yet Nurse Barbie doesn't exist anymore.
Well, that's because so many men are now nurses too.
We have a huge influx of male nurses. Yes, we do.
Which is a very interesting thing, because it always used to be thought of as a woman's job, less pay, less respect, less everything.
Sure.
It's now totally, really changed.
It has changed dramatically.
Do you get paid well?
We do get paid well, I'm happy to say, in 2005, yes.
And you have lots of opportunities. I mean,
Again, the gambit is yours, the palette, as I like to say, because you can all paint what your job is.
And you also can travel. I mean, that's what I discovered when we were in Phoenix, when Jimmy had his brain operation, is that there are nurses that just do that. They go to a hospital someplace for 6 months, and then they live there, and then they go on and they live other places. I mean, it's a great, flexible, wonderful profession.
Prior to my coming to Memorial Sloan-Ketering, I was a travel nurse.
Oh, right.
So I got to go to the University of Connecticut, to the University of Chicago, to the University of Maryland at Baltimore, and I was a bone marrow transplant nurse. So I had a real specialty then to be able to travel into these centers. Same thing, I knew how to nurse, I knew how to care for people, I didn't know where to document, I didn't know how to work the pump. Once you learn the logistics of your environment, you can flow.
It's so interesting.
And I had a ball.
That's so good. Well, Nurse Culkin. Well, let's talk about Nurse Culkin. When is Nurse Culkin running the next time? Nurse
Culkin is a 4-year-old thoroughbred who was named after me. I have no financial link to the horse, unfortunately, because she's really that good. Nurse Culkin is back at Belmont. She spent the winter in Palm Beach, racing at Gulfstream and at the Palm Beach Training Center. And Nurse Culkin is just a fabulous horse, has won over almost $200,000 in her prize winnings, and she's a great horse. And she had the perfect name to be named after me.
Because now, she was named after you. Why? How?
A patient came in, and again, meeting him and his family, and he had 2 little ponies, and he showed us a little Polaroid of the ponies one day, and he came in about 2 months later. He had started on chemotherapy. He did have lung cancer. I'll tell you, it was Mr. Francis Santangelo, just a really great guy, a real New Yorker. And he said, I got you something. I said, well, what did you get? And he had a picture of a horse, and he said, there's Nurse Culkin. And I said, I really don't know how to thank you for a horse, and where am I going to put it?
Well, with that, Nurse Culkin, we're out of time, but people should look in the racing things and see you racing.
Yes.
Thank you so much.
Thank you, Ronnie. It's a pleasure.
You.